Hello everyone, welcome back to our surgical education series. Today we have an important topic on the agenda. In the liver as well series, this will be surgical management of metastatic jejunal neuroendocrine tumor with Bilobar liver mets. So this is a complex scenario that requires a comprehensive approach. The patient today we are going to discuss is a 49-year-old female who was evaluated for pain abdomen in 2008 and was diagnosed with jejunal neuroendocrine neoplasm or tumor with Bilobar mets. She was on adjunct therapies. So this is going to be a very good case and with lot of learnings. I have no disclosures, and in case of any conflict, please refer to the standard textbooks or journals. So I request all my viewers to watch these two videos. One will be on insuloma and another will be that liver as well, which we discussed recently. And for the app users, this video that is this metastatic jejunal neuroendocrine tumor will be available under two courses. One will be that insuloma course and another will be liver as well series. So you can watch in either of them. Friends, this is a very important topic for every surgery trainee, and even more so for the trainees preparing for the super specialty examination. This is going to be a very vital topic. Coming back to the case, so as I said, she was a diagnosed case of jejunal NEC with Bilobar liver mets since 2008. There was no other positive history, and in these cases even it's more important to take a history of flushing, episodic headache and hypertension, which are maybe the sequel of when it is a functional tumor. Patient was a known case of diabetes mellitus for last 14 years using OHAs and insulin. There was no other positive history. The general physical examination was essentially normal with BMI of 27.8 kg per meter square and ECOG 1. On abdominal examination, there were two lumps palpable. One was 9 to 9 cm just below the epigastrium, firm, smooth surface, moving with respiration. Another similar lump of 15 to 15 cm in the right upper quadrant, and as such these were liver lump moving well with respiration. So any lump arising from the liver which is abutting the diaphragm, so they have good movement on respiration. The rectal examination was normal. Friends, this patient is in herself is a book. If you watch and if you read the history, if you go through the everything, then you will learn. There is a knowledge that you can gain. So she was started on octreotide therapy in 2011-13. So this is somatostatin receptor antagonist. She also received 3 cycles of lutetium-177 dotanog lutetium therapy with oral capecitabine 500 mg. That is 2 capsule BD, 1000 mg BD for 14 days in a 3 weekly cycle since 2015, and was also started on tablet everolimus 5 mg per day, and then followed by octreotide depot injection 30 mg, which is given every monthly for the last 1 year. The tumor size was increasing slowly. Patient was becoming more and more symptomatic. And again, moreover, the monthly cost of this therapy, that is tablet everolimus octreotide depot therapy, was costing around 45,000 per month. So patient was, as she was not responding, so patient was referred to us for consultation of surgical management. So friends, there will be many terms which will be new, and I will touch upon some things, and everything cannot be covered, but you have to remember everything. Like she received this lutetium dotanog, she was on tablet everolimus and octreotide this depot injection capecitabine. So you can go through these things through your books, or we will also cover them slowly and steadily as we will add new insight and new videos to this platform. The routine investigation were normal except the marginally raised TLC, and her chromogranin, serum chromogranin A was raised, which was more in 2014 was more than 1200, and at the time of presentation to us it was 198.7. Her CA99 was markedly raised, that was more than 1900. The AFP and rest of the parameters were normal. So again, if you are dealing with a patient with a neuroendocrine neoplasm, then a serum chromogranin is important marker. It is like a tumor marker for watching the progress or recurrence. The repeat CCT abdomen revealed liver was enlarged with multiple heterogeneously enhancing lesions with hypodense area in both lobe of liver in the segment 2, 3, 4B, 5, 6 with large exophatic component, and the largest was 12 into 11 into 12 centimeter. The primary lesion which was in the jejunum could not be assessed because of the collapsed loops. These are the axial images of the same patient, in which you can see this is the arterial phase. So there is there's a well circumscribed mass, well capsulated mass, multiple masses are there which are taking up the contrast in this arterial phase. As the liver is taking the contrast, so is the mass, so it is arterially enhancing. And the hypovascular areas are basically, as the tumor grows, so there are many areas which get necrosed. So these hypovascular areas are basically the necrosed part. You must appreciate this central necrosis, spoke wheel appearance of these masses, which are quite characteristic in these large mets of the neuroendocrine tumors, and the arterial enhancement. Now, in this portal venous phase, you can appreciate that the liver is still getting good contrast uptake, but the tumor is showing washout as compared to the arterial phase. You can notice it now. And as we discussed about the hepatocellular and intrahepatic cholangiocarcinoma, you can very well make out. So you have to differentiate the HCC and this NET. So in NET they are very well circumscribed, and mostly the background liver will be good. In HCC it will generally it is a CLD. And another thing is that history, chromogranin, and important will be the somatostatin receptor uptake study that we will discuss shortly. So my friends, this gallium DOTA-NOC or DOTA-TATE, these are somatostatin receptor studies like a PET-CT. So here the tracer used is different, which has a specific ability for the somatostatin receptors. So any tissue which expressed somatostatin will take up this tracer. And there are two tracers, DOTA-NOC and DOTA-TATE. So this is very specific for the NETs. So it is a one hybrid study of the PET-CT. So this study revealed somatostatin receptor expressing lesion in the proximal jejunum as described, which was primary. So the primary was taking up this receptor, and somatostatin receptor expressing lesion in the liver as described. So there are multiple metastatic lesions. So this is MIP, maximum intensity projection image of the this gallium and DOTA-NOC study. So here it is purely a PET study, and here you can see the contrast uptake. So how you can differentiate between this DOTA-NOC and pure PET-CT will be that pure PET-CT there will be a lot of uptake in the brain, and there will be urinary excretion. While this DOTA-NOC, it has no uptake, only uptake will be in the pituitary. Pituitary has somatostatin receptor expressing lesions. There is a small doubt, I'll clarify in next images. And the liver has uptake, and it is a liver, the excretion is biliary. So all the uptake will be in the liver. And these are basically hybrid images where you combine the CT scan with the PET-CT, so DOTA-NOC hybrid images. And here you can well appreciate that there is a background uptake in the liver while the tumor is expressing such a good ability for the receptor, and the SUB as written here is 35 centimeter. So this is a very good comparison, and how to differentiate PET and this DOTA-NOC I have just discussed. This patient has undergone multiple nuclear medicine imaging, and these revealed intense tracer uptake SUV 22.5 maximum versus 13.3 of the previous. Noted in a segmental wall thickening in the proximal jejunum, likely primary, liver enlarged with intense tracer activity in multiple heterogeneously enhancing lesions, some of which are exophatic. There was no change in size compared to the previous scan. These are the MIP maximum intensity projection images of the PET-CT, and here you can very well appreciate the intense physiological uptake in the brain, which was missing in the this DOTA study, and there is a urinary excretion which is evident, you can make out. the lesions were showing some uptake for the FTG PET also, FTG tracer also, and SUV was 12.5. So again, here I'll take a moment. So this patient underwent DOTA study, tracer study for these metastatic receptors, and FTG study also. So friends, if we are dealing with purely neuroendocrine tumor, like well differentiated, then it will have very good uptake for the somatostatin receptor, that will be DOTA NOC or DOTA TATE, but no ability for the FTG. If we are dealing purely with a cancer, maybe some adenocarcinoma, then it will have very good ability for the FTG PET, but no uptake for the DOTA NOC or DOTA TATE, that is somatostatin receptor study will be negative. But when we are dealing with the undifferentiated neuroendocrine tumors like grade 3 or neuroendocrine carcinomas, then they will have some uptake for the somatostatin receptors and some uptake for the FDG. So according to the somatostatin receptors uptake, if they are taking it well, then only we can subject these patients to the these somatostatin receptor targeted based therapy, as we will discuss more. So just remember for the timing. So this patient, like had both the studies, because it has not a very good differentiated tumor, and it was taking up the FDG with the SUV 12.5, with the otherwise the somatostatin receptor study DOTA NOC, that was around 22. So there were multiple studies, and here in this picture you can again see that there is a maximum uptake in the liver with the tumors showing good uptake, and here you can appreciate that dot-like uptake in the pituitary, and there is no background uptake in the liver, and there is no this urinary bladder excretion. Again, this is going to be a new term for you friends, that is 177 lutetium DOTA TATE therapy, as briefly as I said. So it is the based upon receptor. So if the tumor is expressing uptake of the somatostatin receptor, then you can give them this 177 lutetium, that is like a radioactive material which is bound to these tracers. So she received one cycle of 190 millicurie on 2015, then second cycle in July 2015, and the serum chromogranin at that time was 2375. The third and fourth cycle were given in November 15 and in Feb 2016. The serum chromogranin A came down to 1662 from 2300. So patient had some response to the therapy, that it was the serum chromogranin, which I said is like a tumor marker for these tumors of neuroendocrine region, was coming down. But in the post-therapy scans, there was no decrease in the size, or there was no decrease in the activity of these lesions, as evident in these images. And I think again you can make out now that these are the gallium DOTA NOC studies. Look at the background uptake in the liver and very good ability of the tumors. And in these lesions, even the jejunal lesion, that is in the lower panel on the left side, you can make out, and in the axial images also you can make out there is a very good avidity in the jejunal lesion, which is corresponding to the these metastatic lesions. So in the follow-up scan, there was an increasing tracer uptake in the liver, and there was size was also increasing. And we will end the clinical case scenario discussion here. And now I want to think over the plan, and it may be difficult for you guys. So just scratch your brains a bit and plan the management for this patient. Now, the theoretical discussion about these hypervascular liver mets and the clinical management I'll share in the part 2. So stay tuned. With that, we have reached the end of this video. Do download our app available for Android and iOS, or join the channel membership for early exclusive access to the premium HD content. The link for everything is given in description of this video. And if you are watching this on our YouTube channel, do like the content, subscribe to our channel and share with your friends. Hit the bell icon for all the future updates. And I'll see you soon in the next episode. So till then, keep striving for excellence for your surgical journey. Thank you very much. Happy learning.